Okay, we are talking about Chapter 9 today, so we're going to go through joint classifications. We're going to talk about the different types of joints that we have, joint movements, and we're also going to talk about things that come up and issues that happen with joints. So, a joint is an articulation or an arthrosis, and we're going to have a lot of arthrosis words because that's what a joint is. So we're talking about between bones, between cartilage and bone, or even between teeth and bones. Arthrology is the study of joints and joint diseases, and of course their treatment. Kinesiology is actually the study of movement of the human body. So, we all know that structure and function go hand in hand. Function depends on structure and vice versa, and it is the same thing with joints. So joints that do not allow any movement, that are inflexible, are actually going to be more stable and stronger than joints that are freely movable and very flexible. So you kind of make a trade-off for flexibility versus strength. And the problem with that is that the more flexibility that you have, the more movement you have, the more easily it is going to be dislocated. So flexibility is also known as range of motion. It can be affected by a few things: the shape of the articulating bones, the flexibility of the ligaments, which, remember, ligaments attach bone to bone, the tension of muscles or the tendons, which, remember, muscles to bone are tendons, and hormones, which we're going to talk about those things that affect range of motion in a little bit. So they can be classified by structure or function. Structurally speaking, it's based on the presence or absence of a synovial cavity and what type of connective tissue binds them together. So we have three types structurally speaking: fibrous, cartilaginous, and synovial. Fibrous does not have a synovial cavity, and neither does cartilaginous. The difference is fibrous is made up of dense connective tissue, and cartilaginous is made up of cartilage. So cartilaginous should have told you cartilage. So fibrous, you have a lot of collagen fibers, so very strong. Cartilaginous, either hyaline or fibrocartilage. And then synovial joints have that articular capsule, so they have a synovial cavity and also dense connective tissue. And we're going to focus on synovial joints a lot in this lecture. Functionally speaking, it's based on the degree of movement, so how much they can move, how freely movable they are. Synarthroses are immovable, amphiarthroses are slightly movable, and diarthroses are freely movable. So, structurally speaking, fibrous joints, very tight articulations made of dense connective tissue. Examples are sutures, which unite the skull bones. These are immovable. Remember, we talked about how newborns, their skull bones are not fully united yet, so those sutures have not all fully formed yet. So this is in adults. Syndesmoses, like the distal articulation between the tibia and the fibula. These are slightly movable. Gomphoses, between the teeth roots and the sockets or the alveoli. These are immovable. And the interosseous membrane. Remember, we talked about the interosseous membrane when we looked at the appendicular skeleton. It's that fibrous tissue that is between the radius and the ulna, or the tibia and the fibula. It is slightly movable, but that's what kind of stabilizes the radius and the ulna and makes sure that there's not a lot of movement in your forearm and then again in your leg. So here's a picture and an x-ray with sutures. First picture here is the syndesmoses between the tibia and the fibula. It's at the distal tibiofibular joint, so it's at the one further away from the point of origin. The gomphoses between the tooth and the socket of the alveolar process. And then the last picture is the interosseous membrane. Cartilaginous joints, again, tight articulations, but made up of cartilage. Synchondroses are hyaline cartilage, like the epiphyseal plate between the epiphysis and the diaphysis. Remember, we talked about this. This is where bone growth actually occurs, so it's an immovable joint. However, remember, in children, it's the epiphyseal plate as long as they are still growing. Once they complete growth and are adults, it becomes ossified and is replaced by bone. So at that point, it actually becomes a synarthrosis. And then we have symphysis, which is hyaline and fibrocartilage. This occurs at the midline. And the pubic symphysis, remember, is between your hip bones, so in your pelvic girdle, and your intervertebral joints, your intervertebral discs between your vertebrae. So these are slightly movable. So there's the epiphysis and the diaphysis. You can see between them the epiphyseal plate. And then the pubic symphysis in the middle of your hip bones. And here's an x-ray of the pubic symphysis and the intervertebral joints. Okay, synovial joints. We're going to talk about the 4 things that synovial joints have. The synovial cavity is the unique characteristic of these joints, and it's basically a space between the articulating bones. So if you have 2 bones next to each other, that little space between them is going to form the synovial cavity. Articular cartilage is on the end of each of those bones if you have the 2 bones, and it's going to make it slippery, and it does not bind the bones together, but it covers them, and it's made of hyaline cartilage. The articular capsule is a sleeve-like capsule that surrounds the whole synovial joint and encloses that synovial cavity, which kind of unites those articulating bones. So you have your bones together and they're surrounded by this articular capsule, so there's movement, but they still stay in that same space. And then the synovial fluid, which fills the cavity, of course. This reduces friction because it lubricates the joint, also absorbs shocks, and helps supply oxygen and nutrients to the chondrocytes and gets rid of carbon dioxide and waste. We're going to talk more about these 4 things when we specify specific synovial joints later on. You may have heard people say they're double jointed, or other people say that other people are double jointed. So double jointed kind of gives you the impression that they have more than one joint, but they don't. What they do have is more flexibility at their synovial joints. So because they have this extra flexibility, they can do all of the tricks that they do. So here's a synovial joint, so you can see those articulating bones there. The articular cartilage covering the ends, and then the synovial fluid filling the cavity. The articular capsule surrounding it. So the whole thing there is that synovial joint. There's actually 6 types. The plane joint, the hinge joint, the pivot joint, the condyloid joint, the saddle joint, and the ball and socket joint. And we're actually going to talk specifically about each one later. That's why I went by them so fast. So, classifying joints by function, a little overview here. Synarthroses are immovable joints. Sutures, gomphoses, and synchondroses are your examples. Amphiarthroses are slightly movable joints. Syndesmoses and symphyses are your example. And diarthroses are freely movable joints, and these are your synovial joints. Structure, fibrous, cartilaginous, and synovial. Fibrous and cartilaginous do not have a synovial or joint cavity. Fibrous, the bones are held together by fibrous connective tissue, dense, irregular usually. Cartilaginous, they're held together by cartilage. And then synovial joints have that synovial or joint cavity, and the bones are usually held together by ligaments surrounded by that articular capsule. Oftentimes they also have something called bursa, which we're going to talk about later on, but for now, bursa are little sacs that also kind of help reduce friction and make them so movable. So the articular or joint capsule of synovial joints actually has 2 layers. So it's kind of an extension of the periosteum between those articulating bones, but the outer layer is a fibrous membrane, and that's what attaches the periosteum of the articulating bones to the cavity. So it's very flexible, but it's very strong. It's made of dense, irregular connective tissue, mostly collagen fibers, but it's still very flexible, like I said, but yet strong. It helps resist stretching because of those collagen fibers are strong. Some of the fibers are arranged in parallel bundles and actually form ligaments. So ligaments, again, connect bone to bone. And we're going to focus on a couple of synovial joints later on, and we'll talk a little bit more about some ligaments that are important. The intersynovial membrane is actually areolar connective tissue with elastic fibers. So again, that elasticity is going to allow it to stretch a little bit, but not so much because it's still covered by that outer fibrous membrane. Synovial fluid is a viscous, clear, pale yellow fluid, and again, it's inside that joint cavity. When you're moving, it actually is less viscous, so it gets thinner. So when you warm up prior to exercise, or you should warm up prior to exercise, you shouldn't just go full force because your synovial fluid needs time to adjust. It contains phagocytes, which help remove debris and any microbes, hyaluronic acid, which is a connective tissue binder, and then interstitial fluid for the exchange of nutrients and waste for the chondrocytes. Remember, cartilage is avascular, so the chondrocytes have to get their nourishment somehow. So basically, it lubricates and absorbs shock. If you have something called gout, you actually have uric acid in your synovial fluid, and what will happen is that area will swell. It's usually in your big toe, and it could be indicative of a kidney problem, but the toe swells up really bad and is really painful, and it's very difficult to walk. So it's not necessarily a good thing, obviously, but it can be treated sometimes depending on what's causing it, obviously. My brother had kidney failure, so he still has kidney issues, so he often has bouts of gout, is what it's called. Very importantly, your knee. All of the synovial joints are going to have accessory ligaments. Extracapsular are outside the articular capsule. Intracapsular are inside the articular capsule, but not inside the synovial cavity itself. So the knee has 4 ligaments that are very important, especially if you're going to go on to nursing or anything like that. So they're called the 4 C's. So extracapsular, outside that capsule, you have what are called the collateral ligaments. They're the tibial and the fibular, and you can see them outlined in red on the picture. And again, fibular, obviously by the fibula, and the tibial is by the tibia. So fibular by the fibula, tibial by the tibia. Intracapsular, so inside that articular capsule, but still not inside the cavity, are the cruciate ligaments, the anterior and the posterior. They're often referred to as the ACL and PCL. So if anybody's ever had an injury that you know, a knee injury, and they say they tore in their ACL or something like that, this is what they're talking about. A sprain occurs if the ligament stretches or tears, usually in the wrist and ankle, and there's no dislocation involved. A strain happens when the muscle and or tendon stretches or tears. So sprains versus strains, you're talking ligaments versus muscles and tendons. We also have an articular disc, which is called a meniscus, which is fibrocartilage pads between these articulating bones. They're attached to the fibrous capsule. Oftentimes, if somebody has torn cartilage of the knee, this is the area they're talking about, and you can see the meniscus on the picture there. To repair it, arthroscopy often occurs, and usually what happens is they will go in and kind of shave off any damaged cartilage and then come out, basically. Again, we have to have nerve and blood supply to the tissues of this articular joint, but remember, cartilage is avascular. We also have bursa and tendon sheaths, which are fluid-filled structures. Again, they help reduce friction. So the bursa are like little sacs that are kind of interspaced between the cavity, basically. And again, they're going to help reduce friction. Or sheaths are more like tubes. And again, they're outside the cavity, kind of dispersed all over the place. And oftentimes, if you have bursitis, the bursa are infected or inflamed somehow. So between the skin and the bones, between the tendons and bones, between muscles and bones, or ligaments and bones. So like I said, the bursa are kind of spread out all over the place. They're not actually inside the cavity itself, but they're spread out all over the place. And then tendon sheaths, if you have tendinitis or tenosynovitis, tennis elbow, tendon sheaths wrap around the tendons and can become inflamed as well. So this is showing you the bursa and the shoulder joint, which is a synovial joint. Okay, so we have plane joints, which let you do gliding movements from side to side and back and forth. So for example, between the carpals and the tarsals, you know, there's not a lot of movement between your carpals and your tarsals, but they're not stabilized either, because if they were, you'd break bones every time you did anything. So you have that gliding movement allowed. Hinge joints, opening and closing movements. So this permits flexion and extension. Your knees, your elbow, your ankles, and your interphalanges are hinge joints. Again, flexion and extension. Here's some x-rays. Pivot joint, you have rotational movement. The atlantoaxial joint and radial-ulnar joint are your examples. So the atlantoaxial is between the axis and the atlas in your cervical area there. It's why you can shake your head no. And then the radial-ulnar joint, you have some movement there between the radius and the ulna. If you didn't, you'd have a problem rotating your arm. A condyloid joint, side to side and back and forth movements, so between the wrist and the radius. And the metacarpal phalangeal joint. So here's some x-rays for you. Saddle joints, you have side to side and back and forth, so between the thumb and the carpal. Ball and socket is the most movement. You have movement in multiple directions, so your shoulders and hips. And there's all of those joints. And ball and socket. So I said we talk about this, so here we go. Structure of the articulating bones is going to affect range of motion because it really depends on how tight those bones are together. The tighter they are together, the less motion you're going to have. The tautness of the joint ligaments, whether they're tense or whether they're flexible. The more flexible they are, of course, the more movement you're going to have. But remember, you sacrifice strength for flexibility. The arrangement and the tension of the muscles. So again, it's how flexible you are, how the muscles are arranged, what kind of, you know, if they're parallel or circular or whatever. Contact of soft parts. So if you have any soft parts there, you may have less range of motion. It just really depends. Hormones. Hormones do a lot in our body, and if you take AMP2, you're going to find out about all the hormones. But there's a hormone specifically called relaxin that is released during childbirth that relaxes the pubic symphysis a little bit, only a little bit, so that the baby can pass through the true pelvis. And then disuse is going to affect your range of motion, because the less you use something, the kind of older it gets, I guess. So if you don't use your muscles, they're going to start to deteriorate. If you don't stretch out your ligaments, they're going to start to degenerate, and you're not going to have as much flexibility as you do. Use kind of, according to the wear and tear theory, makes us kind of get worn out faster, but disuse makes things atrophy and die, and so you don't want that to happen. This is a chart showing you the movements that you guys have to know. I highly recommend learning these movements on yourself so that when test time comes, do the movement if you have to try to remember what's going on. So flexion is a decrease in the joint angle. Extension is an increase. Hyperextension is extension beyond the anatomical position. So if you hyperextend something, it's really painful usually, for the most part. I mean, you can put your arm all the way back and that's not hurting, but if you hyperextend your elbow, for example, that's going to be very painful, or your knee. Abduction versus adduction. Abduction moves away from the midline. Adduction moves towards the midline. So you can think about it a couple of ways. If you are moving towards the midline, it's kind of like you're adding to it. If you're moving away from the midline, I always think that if somebody's abducted, they're taken away, so away from the midline. Circumduction is a circular movement. Rotation revolves around its own axis. Elevation is superior, depression inferior. Protraction is anterior, retraction is posterior. So you move your bottom jaw, your mandible out versus back. Inversion is the medial movement of the sole of your foot. Eversion is the lateral movement. Dorsiflexion moves the foot towards the dorsum. Plantar flexion moves the foot towards the plantar surface. Supination, your palm is up. Pronation, your palm is down. A student told me once that she remembered supination because if she wanted soup, she had to have her palm out. Hey, if it helps, it helps. And then opposition, touching your fingers to your thumb. And then here's pictures of all of the movements, of course. So make sure you go over those in your book. And like I said, do them on yourself. Learn them on yourself. I'm also going to be telling you in the muscles time to learn the muscles and the movements of the muscles on yourself, because you're going to have yourself at the test. So you can do the movements and try to help figure out what muscle's moving. Okay, so here's a table from your book also showing you these special movements. Okay, selected joints. We're going to look at the temporomandibular, the shoulder, the elbow, the hip, and the knee. So the temporomandibular joint is a combined hinge and planar joint formed by the mandible and the temporal bone. It's the only movable joint between the skull bones, so it's the only portion that can actually freely move like that. And then you can see the picture over there, of course, and the synovial cavity pointed out. Another angle. Pictures, I guess you could say. The shoulder joint is a ball and socket joint formed by the head of the humerus and the scapula. It kind of rests in the glenoid cavity. Remember, the glenoid cavity is not very deep, so the shoulder has the most freedom and is the most easily dislocated. The elbow joint is a hinge joint formed by the humerus, the radius, and the ulna. And you can see some of the ligaments there. The hip joint is a ball and socket joint formed by the femur and the os coxa. Now remember, the acetabulum is where the head of the femur sits, and it's a lot deeper, so it's harder to dislocate your hip joint than it is your shoulder. The knee joint is a modified hinge joint, and this is actually the largest and most complex of the body. I already talked about the 4 C's, so you have the fibular collateral ligament by the fibula, the tibial collateral ligament by the tibia, and then the anterior cruciate and the posterior cruciate ligaments inside of there. Another angle. This is showing you that articular cartilage really well, how smooth the surface is. Also showing you the menisci. Showing you the knee joint, and again, look at that articular cartilage, how smooth it is. And then it's got the tibial collateral ligament by the tibia, fibular collateral ligament by the fibula, anterior cruciate, and posterior cruciate in the middle there. Aging on joints is going to vary depending on who you are, but by age 80, almost everybody develops some sort of degeneration in your knees, elbows, hips, and shoulders. So you can't avoid it to an extent, but you can postpone it. The better shape you're in, the less sports you play, but the better shape you're in, I guess, because if you play sports, you're more prone to injuries. Osteoarthritis is at least partially age-related. As we age, the articular cartilage starts to thin out. We do not produce as much synovial fluid as we used to, and our ligaments actually start to get shorter and lose their elasticity. So joint arthroplasty is a surgical implantation of an artificial joint. The most common, your hips, your knees, and your shoulders. Partial hip replacements only involve the femur, or you could have a total hip replacement that involves the acetabulum and the head of the femur. So here's an x-ray showing you, or a radiograph I should say, and there's a picture looking at what it is. So you have that artificial acetabulum up there, and then the artificial femoral head going in, and then the metal shaft. Oftentimes they will use titanium because titanium does not have any antigens or anything to elicit an immune response from us. So titanium is a good thing to use for any kind of metal replacements in your body. So that is it. Osteoarthritis is probably the most common issue that we have going on in your joints. And a lot of theories out there, one of them, again, the wear and tear theory, that just by simple use you start to degenerate, I guess, in a nutshell. And as I said, you can't avoid it completely, but you can postpone it. So try to at least walk on a daily basis. You don't have to exercise every day and go full blown. Do what you can do. Everybody has their limitations. I have back issues myself, so I try to at least walk a little bit every day. So do what you can do, and that's the point. You can only do what you can do, in a nutshell. So as always, if you have any questions, just send me a message.